Okay, we want to talk today about closing space on adults. Uh, there's a lot of people, studying orthodontics and that have not had any experience with closing space. And so a lot of times you're not accustomed to using that or thinking that as you're diagnosing the case, and you may not think of some of the things you can do by eliminating some bad teeth and using some teeth that you have, and probably like wisdom teeth that you're thinking of eliminating down the line. This seems to be something that people have been kind of brought into, that wisdom teeth aren't any good and that they should be eliminated anyway, but they're excellent teeth. And if you've got them and you have some bad teeth in between, frequently we'll just go ahead and remove the bad tooth and then just slide the teeth behind that space forward and close the space and utilize the wisdom teeth. So that's one of the things that you need to think. You have to do it a little bit to it actually becomes a part of your diagnosis, and you realize that can be done. So here's some two cases we'll go through. These are adults that are, I don't know how to guess their age, but they're not teenagers and they're not in their 20s, and I think they're in their late 30s or 40s or getting on up there close to 50. And you'll see some of the problems that come up in doing these cases. The first case here's I don't have the absolutely first pictures of her here with her teeth crooked, but she came in with a tremendous bunch of gaps and spaces and tilted teeth and stuff like that, which I'm going to show you with some x-rays in a minute. Just a real nice lady, and actually her dentist sent her over there for me to kind of upright some teeth so he could go and do a bunch of bridge work on her. And so excuse me, I'm going to go back, and this is giving you another view of it. This is a good face to me when you look at somebody and the dimensions are like pretty well divided up into thirds, and it looks good. And so you can do a lot of things with cases where the facial structure is good, and if you got a real high angle and you start moving things around a lot, you can increase the vertical dimension of the face. But on a case like this, you won't do anything. It'll still be. We'll look at her several years later. I've got some pictures. I think we started about 2000, and I've got some 2008 pictures on her. So anyway, here's her teeth, and this is 11th month of 2000. She has a terrible deep bite. I mean, this is a kind of a class 2 division 2 anterior situation right in here, and we're going to open this bite and level the teeth up. And I started doing all this, and then I started trying to close the space or see how it would close, and man, it just went together just real good. So we didn't stop. We just kept closing spaces on this lady. Now from the side, you get a mouth here that's really collapsed. She's lost a molar in this area, and this second molar leaned over in this area, and one gone up here, and this tooth comes down and its mate moved out from under it, and so it's kind of over erupted, and you got a whole bunch of problems in dealing with this type of case. And the wear and tear on the teeth is in different positions, so that makes it kind of bad too, where they come together like that. Now really, if you open this thing up and line it all up, your upper cuspid and everything, it's in a class 2 relationship, and you're going to need to bring this part, and bring this back, and maybe bring this forward a little bit to get it into more of a class 1 relation. Here we've got a big old gap here where I guess a second bicuspid was missing, and they just left it out. And of course this dropped down in the hole, and you'll have to level all this out. And this is a wisdom tooth that I had thought of maybe discarding. We'll go look at it on the x-ray. But after, her dentist had planned to remove that. Thank goodness he didn't take it out, because we started working on it, and we just brought all these teeth forward and closed that space and brought this one up, straightened it up, lined the root up, and put the two teeth together. And then raise this one a little bit and line all this up, and then pick up these front teeth. So when you have these adults that have this kind of a class 2 division 2 bite, where their lower anterior teeth are just banged right up against the upper anteriors, when you straighten these teeth out and get them out and bring these down some right in here, their bites will just move forward. They want to close their mouth further forward, but this interferes with it, so they've chewed back here for years. But when you get rid of the thing that locks it back there, the jaw will tend to come forward quite a bit of the distance. In fact, I had one case one time, class 2, division 2, and we straightened it all out, and I had used some class 3 elastics to finish the case. Okay, that doesn't happen very often though. When we look at the upper, we're going to bring these way out, you see, and we'll pick these will come up in the arch too. You can just watch some of this. We'll taping these things and putting them down like this, you can't answer questions of people. It's much better if you've got people in the audience where you can discuss the case with them. But anyway, I'm going to try to point out as many things that I can think of as we go, but a lot of times I forget what it is. Here's what we had planned to do in the first time. They said May. We thought, we would just put implants or bridges in a lot of these, maybe straighten that up, put a bridge in here, and stuff like that. And we were planning to bridge this. So we kind of write this down on your x-ray when you start. Well, I've got her age here. She's darn near 50 years old. Well, she'd be 50 something when we stopped. And this was the 11th of November in 2000 period. Now we'll have some x-rays later on. So here we are, about in the middle of treatment. I don't have a whole stack of treatment deals, but we've raised the anterior teeth and opened the bite, and we've taken these teeth down with these intruding arches and stuff. We'll have to show those in another video on how we do intruding arches to level it out. And this has been raised up and they've been brought forward, and now she's virtually in a class 1 relation. Now I had class 2 elastics on here, which I don't show any pictures of and stuff. It was just interested in showing you how to close these spaces in this this little video that we're taking. So this has come way back. This cuspid was way out here. You'll have to look at it on the models but it's moved back and the lower jaw has just come forward quite a bit right here in the correction of this case while we were closing all this space up, you see. On the other side, you can see where we had class 2 elastics. Sometimes we'll put one elastic here and come back with another, or maybe we'll take one of these and go on the lingual side and pull forward with that to put a lot of pressure on it to actually back these teeth up some and bring the whole thing forward to some extent there till you get it to class 1. Now you look at the upper arch and it is pretty well lined up now from where it had that class 2 division 2 situation. It's looking quite well now. I wish we had another tooth to stick in that spot there, but so far we didn't have that. Now this tooth, the enamel cracked off of it, the crown was on there, and we finished it like this, but it's got part of this enamel broken off that crown, and she had to have it redone later. And but this was off when we started the case, working on it. But it's lined up pretty good on the bottom too. Now this is just showing the case a little further down the line. I'm sorry, this is a mirror shot, but it shows you we're back pretty well to class 1 relationship, and we got the lower anterior right up behind the upper anterior there. That film is not in focus. Now we got a little better focus over here, and here's the crown there where the enamel part of the crown is cracked off, a part of it. She'll redo that when we finish up here. Now the upper is looking very good there, and now the lower looks quite well too. That's a little over too much light on that slide right there. Now here, if you wonder what this wire is, we lace the anterior teeth. Maybe we had a space in here and we wanted to close, so we just put this lacing over the brackets, you see. You can take your arch wire out and change the arch wire and still leave that lacing in there. Then you stick an Explorer in here and crank this thing down, and boy, you can close space, and it'll pull the cuspid forward and bring these teeth back together. And if you've ever built any barbed wire fence, you'll know how to do this. We'll do that on the post. Now that's just another group. Okay, we'll go back. I'm going to go through some of these x-rays. Now this is 2011, 15 of 2000 when we started. And this tooth was tilted over like this, and we decided just to bring it up all the way here. And this one we'll bring it forward and close this, and this tooth right here will drop in behind if they want to wear a little flipper or partial or something to catch it. We might be able to, in bridging it, to extend the bridge back enough to catch that tooth to keep it from just over erupting too much. Now the trick of moving these roots forward, you see, as you correct it, anybody can pull on them and they lean over like that. They rotate on a point like here. But now watch, this is a tooth that's had root canals, and you get in adults here, you're going to end up with all kinds of periodontal troubles and root canals and missing teeth and crowns and abrasion of the teeth and how they've worn in crazy ways, and some have the tops, the crowns chipped. Now this is a clove bite, you see these. Now I take the Panorex with a paper person biting together in the way they chew, just close their teeth all the way together. See, the lower anteriors are coming up to here and the upper anteriors come down to this point right here, and that's far too much of that. So we'll show you what that later on when we look at it, you can see what happened there. So if you notice, let me go back and point out one thing. You see this gap right here? And we've been pulling on that for some time. That's 2000. Now this is 7/11 of 01. That gap is no further together than when we started, but look at the root structure. It is coming on here, and we're going to upright that tooth as we come forward. We're closing this over on this side, and the tooth is staying parallel with the roots are parallel, and we're bringing the second molar forward, and then we'll put the wisdom tooth up underneath that. You see, we'll utilize this wisdom tooth. It'll come up and meet this tooth above. Let's go back and just look at see the tilting part of this tooth right here. See how it's leaning like that, and this space is like here. So we're pulling on it, and you wonder, well, how did we get the force down here on the roots, you see? And this crown will end up being leveled out right along here, and the roots will be directly underneath it. So you can see how much of that is taking place. The roots have been moving, but the crown hasn't. Over here we're moving the tooth forward bodily. So what the way we do that is that we put a bend in the wire, a tip down, and then we slide the tooth forward on that. I'm going to go over here to just to make a page, and you can see this tooth is, say, sitting something like this, and you've got another tooth right up here. This bicuspid was somewhere in this area, and we want to bring this forward here. So we'll take an arch wire, and at this right between these two teeth, we'll mark that, you see, and we go down and make a little circle like that, and then the tail end of this we may activate it that much. So I'll have to put that in the tube of this tooth right here, and actually the arch wire then will be tilted way down here, but we raise it up and hook it to the teeth. And as we pull that wire, when we get it hooked up, you see, this is going like that, but now it's going like this. And this spring alone will bring this root forward. And we pull on it. You can attach it here and come in and pull. And as you pull on it, the root comes forward, but the crown will stay there until you get it lined up and get it pretty well parallel, and then bring it on, finish up the deal together. You have to learn how to bend some of these crazy little wires to be able to move them like that. So this tooth here, we had a similar thing right in here, you see, and this would be going down, and we raise it up, put both teeth, and we're pulling them both forward, so they'll both be down and leveled out more like that. So you can see this tooth is coming along just pretty well parallel. There's no problem with it. And this is 2002. So this is January, February of 2002. And so at this age, this time she's 49 and a half years old. And we've taken some time now. I'm not saying you can do this overnight. And we're pulling all these spaces together and keeping the roots pretty well parallel as we bring them together. And the wisdom tooth that I thought eventually you would remove, we put it over here and watch this tooth at the end. We have some stuff, I think, in 2008. You can see where she is. Okay, we're coming along here further, and here is this intruding wire. You see this wire comes out. It's got a little deal like that. And that wire would be headed down, way down below this, and come back up. You raise it up, so it's pushing down on these teeth. And we had one pushing up on the front teeth to start with. So there's a lot of mechanics in here that you won't learn here, but I'm just showing you what can be done with adults and anybody. I don't care how old they are. If they were 80 years old, come in, I could close the space on it. And you should be able to do that too. And so you think of that as part of your diagnosis. You really look at it. What would you like put in your mouth? Would you rather have a bunch of bridges and implants and stuff like that, or would you rather have your teeth pulled together and close the spaces like that and just have your regular teeth in your mouth? I think most of you would want to have your regular teeth. So this is the fourth Panorex. Here's the fifth Panorex we took, and this space is darn near together at this point. This one is too, and our space over here, we're moving it together, and you can see the periodontal membrane will look real thick around the teeth. And if you stop and wait there a while, then the bone fills in around it. And now you remember this wisdom tooth. When we close all these up over here, now this wisdom tooth's going to come up, and we'll grab it and straighten it out, or just let it erupt up against those if the patient's tired, because we're in 2003 now. See, this is January, February, March 2003, and I think we started 11 of 2000. See, so it's just a month in. We had 2001, 2, and 3. So we've taken some time to do this, but look at what you ended up accomplishing for this lady. Alright, here's 6 months in 2003, and she's 50 years and almost 51 right now, and this is the sixth Panorex, and we've pretty well got everything together here. And I see this tooth actually is covered up with some tissue, so I didn't really stay long enough in the case to catch hold to this and straighten it up. But this tooth will erupt up into here, and it'll chew on it there, and it will tend to parallel itself out over a period of time, so you don't have to stay there to totally do this. Now, I've got these roots too close together. I had too much forward tip in that root. That should be down like that. We've got one more Panorex later on. We maybe did some of that, but that's not perfect, and I'm not saying I'm doing perfect. I see a little space right in here, so we've got that looking better now. And this tooth right here is got a space between it, so it can drift up and come on in underneath that tooth above. She could put an implant down over here to oppose this tooth if she wants to when it comes in. Now, here we are. I don't have the dates exactly, but I'm going to go through several slides showing you the case after we finish. Now, you remember this cuspid was way up like that when we started, and we moved it back, or actually the maxilla has been brought back and the mandible brought forward, so we got it pretty well in class 1. This side is a very similar way. Now there's the upper teeth. When we look at it, 2000, and here it is. It's a very poor picture, but you get the idea. I mean, it's straightened out quite well. Here's the lower in 2000. See how crowded that is, and yet we straightened that all out and brought it forward. Now we've got a 3-to-3 retainer bonded on everything on the bottom. This tooth, the enamel structure over the crown broke off, so she had it redone later on, so this whole thing is re-crowned in some of the later pictures here. Okay, this is pretty well sucked into a class 1 relationship for this lady, and the spaces are completely closed. That's just got a, we've got a mirror stuck in the cheek back there, so you're looking at these teeth from an angle from over here, so you can see them straight on. And this same mirror, we just swapped it over on the other side, and this is the tooth that this enamel breaks off even more here, and they're going to redo that whole crown for her. Now this is where we had a big gap here. We brought the 2 molars forward, and then we took the wisdom tooth now is underneath there, and this tooth is coming down and will occlude against that wisdom tooth that we thought of throwing away when we started. Now this is 2004, this is number 7, and it's awful dark. Sorry for that. You can't really see where the root structure is there on the teeth, but anyway, we finished this case, took it out. You see that enamel structure broke away from this tooth. Now the orthodontics may have had something to do with it. I banned that tooth, but that was a pretty sorry crown. It wasn't done as good as it could have been. And she comes back and gets this redone right over here. Now we put a wraparound retainer. I never put anything across the occlusion because they bite on the wire and they move the teeth one way and they take it out and their teeth move back in another direction. So this is both upper and lower wraparound retainers that we put on her, and I do this on adults. In other words, we pull those teeth up there and you don't have bands on them. Now back when we had banded teeth, it was even worse because you had to close all the band space. So here we can close everything up except where we had bands on the molars, and we go ahead and close that too, and I can hold it together with a retainer, so I don't think she wears those all that much. We can squeeze this together, see, and bring these teeth forward and have them fit tighter, and your retainer allows them to erupt into each other more. Now she's over 50 till we finish her. But look how this is socked in now. See, that cuspid's tucking in there and really fitting down. So they tend to kind of erupt together after you finish this, and then you keep them from getting deeper by we put a little soft acrylic on this, you see, and put it in her mouth. We build the base of this retainer. It's made out of triad material, so we don't lose this model we made it on, and we get that fitting good, and then we'll get the bite, the depth we want. You add some lump of acrylic right up in this part of the retainer, and I'll back up here one slide, and so then you slip this in and you have them closed together like they chew. You want to have their head straight up and down. You don't want them leaning their head backwards or forwards. That changes the position of the jaw, and let her bite into that acrylic, and then the bite will never deepen again. So these, as long as they wear that. Now these teeth were way down here, you remember, when we started, and so they've opened considerably. Yet we didn't increase the vertical dimension of the face all that much, so these teeth right here provided the force to lower these and raise these, and it will pick them up a little bit. But if your occlusion's good and they chew on this good, then these teeth won't come together very much. They won't you won't gain too much vertical. You can look at the face after you finish. Alright, this is the bite plate on there. and we'll cover that late in some more videos. Alright, now we didn't try to close this tightly because I wanted this tooth to catch maybe that upper wisdom tooth. It might drop down over a period of time, and you could build a crown and have a little extension on it out here, and then have an extension back in the back and catch that upper tooth, which might be a possibility later on. Now the lower teeth has come along, just about finished everything. Now this is 2004. We've out of this. She's got her mouth open now. As she closes, this will come back, and kind of like that. Let me see. Okay, she's closed over on this side. That's the right, and here's the the left side, and there's not much enamel left on that crown, so they'll come in and redo that. Now the midline's off just a little bit, but probably the tooth sizing in here is off too. So here's her facial structure after we've finished. We still don't have, we don't have too much vertical down here, so it didn't open the bite hardly any. And then she's got a nice smile line. You see, you don't show a lot of gingival tissue in the smile, and it's really changed this lady. Now here's a here's a picture. A lot of people you like to see this really, so just stick a mirror right on the lower anterior teeth and take a shot looking down in this direction, and it will give you a view how these lower anterior teeth meet the upper anteriors in here. And so you've got to get some smooth situations in here. This tooth is slightly rotated. We just didn't get everything just perfect in here, and it's a little bit on the crowded side. But people who have these large gingival margins or cingulums on the teeth, you'll see this in Hispanic people and Oriental people, and a lot of people will have this, so you may have to go in and smooth those things out if you get this to stay. Because where one of those hits one corner and then you don't have it hitting another, those teeth, just almost impossible for them to stay straight with when they're hitting something like that, you see. So smooth that out and make a little bite plate out of where the base of it is. Let them chew up against it. Okay, here's the 2000 model, and here it is in 2004, I think. So we've opened the bite that much. Now look at where the cuspids are. You'll see that better when you look at the side of the model. So let me go on to the side over here. Now this molar is gone, and this cuspid we're going to move back in here as we raise these teeth up, take these teeth down, straighten this up and pull together, pull all this together up here on the top. So you can see these molars are brought forward, and they're including the grooves fitting right in the base of that. We come across, and now it's pretty well class 1, you see. And this will come back, and it'll drop into class 1 too, as we come and bring this forward. So we're going to take these teeth, put them right up in here, and then this wisdom tooth, we'll have it up underneath here, and this will come down and probably touch this wisdom tooth right here. So actually this tooth will pull up underneath here, and you leave a little space in here, and that will catch maybe catch this tooth as it drops down if you want to keep it. Alright, there's the, okay, here's 2005 right there, and you've got a bicuspid actually coming against a molar, and she's had this crown redone, so they built the crown so it would occlude against these teeth. That looked like they crowned that one too, coming in here. And here is that wisdom tooth back here is going to oppose that second molar up above. Now there's the lower arch in 2000, and there it is, I guess, in 2005. That's that crown they redid over there. And there's the upper, you see where those upper centrals are. You see where they are now. And look at how much better the whole arch is rounded out, you see, as we did that. And if you go back here, you see you've got a more narrow situation. So we broadened this thing out a lot and gave us room to put those teeth in place. And here's some pictures of her. Well, we've looked at those pretty good. Now this is a little later on. I really ought to have shown her how to scrape the calculus off those teeth herself, because it probably forms in a matter of a few weeks, so she doesn't get it cleaned off enough. And the cuspids are sitting in pretty darn good class 1 relation now. And this is settling in. Now this is, okay, these are 2008 shots. This is 8 years after we started the case, and it's holding up quite well. And you see how the teeth, they erupt together in this type of retention, and then they wear in again at that point, you see. This is 2008, and we bonded that. We got a little flaw right there, which we just didn't get it perfect. Now this is a mirror stuck over the tongue, so that I could show that last wisdom tooth back here at the back of the mouth. But when you look at it, you don't realize this is a mirror laying down on the tongue. It looks like a crazy set of lips right there when you look at it that way. Now the upper, we have no tooth in here, and we put this around the other teeth, and this is where the lower wisdom tooth is catching this, and then the second molar is catching this 6-year molar, and the first molar comes in underneath these bicuspids right in there. Alright, this is the lower retainer that we wore for a while till those teeth settled in. I didn't want to take a chance of that backing up any in there. So here's some pictures of her, 2008. Alright, here's another case, and I know you're getting tired of watching all this, but she had 3 pretty badly broken down. They had root canals and a bunch of stuff done on some molars when she came in, and so we suggested this to her. This is 2009 when this lady came in. There's herself, and this tooth here was really down on the nerve, and she was going to have root canal and probably have those crowned later on, so a lot of expense there. So we took this tooth out. These teeth were where we wanted them, so we put a tad in the cortical bone right on the side of the tooth. You don't have to have it touching the tooth at all, but then etch the tooth and put some real good composite on that tooth and bond it to the tooth and bond it, or put the whole head of the tad in there. Now, then we pull back on these teeth and bring these teeth forward, but these don't move back because of this little screw in the bone over there. And then that's a neat trick. You can just screw the tad right down into the cortical bone, you see. And it can be to the side of the tooth, and you can flow this composite, can come out around the side, and you can pull on this and they'll just stay there, and that holds that while these teeth move forward. There's a lot of uses for tads. And so let me go back. I jumped to x-ray here. We had two other teeth. This one had root canal, and this had a little problem in here, so we decided we'd just take all of these 6-year molars out, and she had one of them out to start with, and she was missing this tooth up here, and this was still in there, but we had these teeth over on this side and we lost the tooth up here, so that was good. We took these out, and now we're going to bring these forward and close the space. Now here we had these where we wanted them, so we put the tad in. Let me get that out of the way. You put the tad right in here and bond it. It doesn't have to be behind the tooth. You put it beside it in the cortical bone, and then put your composite around the head of that, behind that tooth, and then we'll pull all this forward by pulling back on this on the anterior. Now over here we don't mind. We'll pull this back as we pull this forward, and we'll back these up together and close this space. Now this is what I would want to do in my own mouth if I had these bad teeth like this, rather than keep this tooth and this tooth that were bad and extract these. They're crowded out back here in the back, but just keep them and we'll just move them forward into that space. And if you learn how to do that, that'll become part of your diagnosis. You'll go ahead and figure that into it. It's what you want to do. But if you've never closed one up and you don't know anything about closing space, you'll think about bridging and putting implants in and stuff like that. Whereas if you learn how to close the space, you won't have that problem. Alright, here we start out. Now if you're going to extract the teeth, we did something wrong here. You should not take the teeth out. Don't take any of these teeth out till you have the bands on the other teeth. You got your brackets and everything on there, and you're ready to go. Then pull the teeth and start closing the space the same day, the very same day that you do that. So you extract them and kind of stop it from bleeding, but you want to have all this on there. Now we didn't wait long. I mean, we took them out and got her probably back in the next few days, and start this. But it's better to put all of this stuff in the mouth and then extract the teeth. And that day start pulling this together. So you'd have to put this tad in early like that, you see. Alright. But it worked. Here's the tad is in place, and we bonded it to the back of it. It looks like a big one. It looks like it's a pretty good size screw in there. But look where this has come to now. And that's holding these teeth back. And these teeth, if you go back and look at this first x-ray, well, how in the devil did you get that one underneath there? You just pull on this thing, or you can actually put a little block of acrylic or something to open the bite till you get the corner of this one underneath there. Once you get it underneath, you can take that off and go ahead and close it. But you look where it is there, and watch where it moves to, see. we've got it in there now, going up, over here, you're just pulling the two groups together. A little simpler deal. Now here, this is already through, and it's about halfway the distance. Now you pull this up. Now this screw is out to the outside, so you can get up closer, and then at the last minute you have to take this out, and then you have to close that with class 2 elastics. You see, you can close with your arch wire, but you keep this in class 1 relation, and then finish it up with class 2 elastics up there. Okay, I think this is getting pretty close. And you remember the little arch wire I showed you closing that? We had this together and pretty well parallel. This is one of those arch wires. You go back and you bend this around like that, and then this goes down here, and this is put in here, and as you pull on this, it tends to move these roots forward along with the crown. It'll move right along with the crown, and this pretty well is parallel right now, so we don't have a problem. I think this is the newer X-rays. I just did a printout and took a picture of the X-ray itself on a piece of paper like that. It's not quite as good to do that. Now you can do this stuff. It's not, just try it, go ahead and work on it. Now here it is, January 2011, and we've got this pretty well close together, and I don't know the date on this picture. I don't have it written down there. That's January 2011, and maybe that was the same day. I don't know. We took that off. That's January 2011, and here it is. Well, I've got the date. This is 7 of 2011. You can see down here. And now that's completely up there, but you see it looks like you got pockets around the tooth, but as you move the tooth, the bone structure moves out, and you x-ray it, and it looks dark around, and then you leave it for 2 or 3 months and x-ray it again, and you'll see the bone fill back in. It doesn't create a pocket like that, like you might think it has a pocket on that. And so we close this up quicker than we did this on the other side. And now this lady, well, people will look at her and think 9 out of 10 dentists won't know these three are wisdom teeth. You see, that is supposedly, I guess, a second molar. I don't know. Those teeth had already drifted up there, so parallel, I assume that she had lost the wisdom tooth, and it may have just drifted too. That may be a second molar and a wisdom tooth up here too. So that's here it is, another. This is 7/2011. That's just before we took all this off, and now we'll run through it, some of the material on here as we did the case. The mechanics of closing it. You put these little tilt downs, and that brings the tooth parallel. As you get this one banded back here, you'll need to run the wire through both of them to bring that on the top. A lot of times we don't have to band this one. On the bottom have to band every one of them, of the second molars. Now here is this tad right in here, and we bonded it. Looks like our bond may have broken, but we pulled on this, and these teeth stayed where they were. As you pulled over here, these came together. If you look at this carefully, you'll see the curvature of the arch is a little different on the right side than it is on the left side. We'd have to kind of balance that out after you stay there for a while, but it'll help balance that thing out. But right now it's a little distorted to one side, and these tads just hold their place. If you get one down in a good cortical bone and then bond it to that tooth. Now here we're in a class 1 relation all the way around. It's got her mouth open there. Here's one of those little springs, you see. And here's another one right here where you bend that down, you come around again, and then you bend this up like that. Then you tie through this loop, and it pulls it forward and keeps the roots parallel. The last thing out, you take the tad out, because the molar's up against that bonding agent, and then you have to use some class 2 elastics to pull it the rest of the way. Now the curvature of the upper arch looks good, and the bottom looks, it's still got some distance to go here. Let me kind of hurry through this. Just the mechanics, we're not trying to cover that now, it's just trying to show you can close these spaces, and so let that be a part of your diagnosis. Now, after getting back here and everything, taking this tad out, this side, both sides have pretty much even contour to them. And this is come forward, but now here's that little deal, you see, and this wire goes down like that. So as we pull that up there, and you can, if this butts against here, you can just still move that root of that tooth forward in that area. So that's the way we bring them. We close the space and keep the teeth parallel. Okay, that's the original, and there's the final, just before we took this deal off. So this is the end of this little video on closing space on adults. It's something you can do, and I hope that many of you do this and learn. If you don't, learn how to do that, because really you can do so many nice things for people, and they want it. It'd be what you would want if you were having your teeth straightened. So we're going to close this out now. Hit F10. Okay. We've started recording, and this is Dr. Bill Waytt, and I'm going to record a deal on class 3 non-surgical correction, and we've got a couple of cases like this I'd like to show. I want to get my little marking pen up here. Okay, the recording is on the way, and it's early in the morning, and I'm down here working on this case. These cases are treated by removing both lower 6-year molars. The lower 3rd molar must be present to attempt this. Now we've done some pretty bad class 3 cases simply by removing the lower 6-year molars and bringing the lower anterior teeth back to class 1 and the lower 2nd and 3rd molar up to class 1 position. So we'll go through this case, and I'll show you what I think is something we should be doing. This young lady came in, and you can look at her face. There's no question about her being class 3. She's got a very prominent lower mandible, and just looks like it's a little deficient right in the upper part of the facial structure. The base of the nose needs to be filled out a little more. So we'll look at this after we get through. Now, I've known this lady for years. In fact, she's still, she was in Glenrose and I was in Hearst, and we moved to Glenrose, and she recognized my name, or my wife, and asked her about it, and so we found her after years. So we've started this case in looks like February of 1987. So now we look at the face from the frontal view. Let me go back and erase that now. From the frontal view, and you still see this deficiency right in this part of the face, and this is prominent in this area. So it's a definite class 3 case. Now when she smiles or opens her mouth there to where you can see the teeth, you can get a better idea of the class 3 problem. Now if we look straight at the molds, I mean the upper centrals are fitting behind the lower centrals, and these are crowded up. If you straighten these out, it would even be more out to the front than it is now. And if the thing we're going to do is just common sense to me. We'll come back here and take out these 6-year molars, and then we're going to bring these teeth back to a class 1 relationship, and we'll be pulling them back by pulling off of the upper in this direction. We'll also be pulling them back because this tooth will be gone. We'll be dragging these teeth forward, and the force to bring them forward, we bring this back too, and then we can substitute class 3 elastics in the case to make sure we come out on the class 1 side. Now these teeth are kind of torqued back from the lip pressure, so if we torque them forward, it's going to make these teeth look even worse, and we want to bring them back in a proper torque relation. So you've got to bring the root structure of these teeth back, and this is a pretty difficult thing to do. And we like to bring these teeth forward, and we like to move their roots forward too, so we can keep them torqued properly. And so you're actually going to kind of move a point out up above. So it's a pretty, the thing that happens is pretty complicated, but to do these cases is not all that difficult. So I don't want you to be afraid of trying to do this. Now we're going to take out these teeth right here, and we're going to move this tooth up to a class 1 relation. It'll be something like that in relation to this upper 6-year molar. And we'll bring these teeth backward, and we'll take this bicuspid and put it right in this area here. Then the next one would fall into there, and then our cuspid would come in this fashion up in here somewhere, and these teeth would be under. We'd expand and straighten these out. We'd straighten these out, and you have an overjet and overbite. Would be pretty normal when you get through with the case. So we'll show these models when we get to the show, so you can compare what's going on here. And we're going to do virtually the same thing over on the other side. Now when you get through, this tooth won't have anything to come against, so you can just leave it there. It's not going to ruin things if it's there. So we'll go on to the upper models. As we come forward with this maxilla, we need to widen it out. So we're going to use a large, what we call our Big Daddy arch wire. We'll have it out something like this and bring these teeth out to meet it. We'll also have to kind of get this one to come out with it in that area. Excuse me, let me go back to that picture again. So we're going to expand the upper arch in doing this. Now this is an 040 wire we put in here, what we call a Big Daddy arch, and you can expand almost anything that's alive with it if you want to. Now to bring it out, you have to put buccal root torque in it, or you're just going to lean this crown out, you see. So you put buccal root torque back here in these teeth. That brings the roots of the teeth out as well as the crowns of the teeth. So you need some of that in these up here. You may even have to band the upper molars, but I don't think we did to get the buccal root torque in the upper second molars. So let's watch what we're doing here. Now on the bottom we've got an interesting situation. You've got a tooth that's almost 90 degrees rotated. It's really not. It's about something like that. But whenever you have a extremely rotated lower anterior tooth, you can figure on having to strip the gingival tissue, and also some of the bone structure will be stripped off of this root when you rotate it. There's not much way to do that. You could, if you could get a bracket on the edge of this tooth and torque this root back in, you might could avoid that, but we didn't go to that extreme to do that now. And of course we're going to extract these 6-year molars. We're going to bring this back about here and bring this forward up to about there, something like that on both sides. Now when we look at it cephalometrically, you can see, get a good view of the condyle. You see where it's up in here, and the pagonian, the bony structure here, is out front. Now we're going to bring these lower anterior teeth back, and I want to have them, the roots brought back too. And when we get through with this, you're going to notice that we did not move the chin button, but we moved the teeth on the jawbone, and it moved back about that far. So we'll look at pagonian when we get through, and you'll see that it's something like that. But it's not, doesn't withdraw, doesn't mess up this young lady's looks. If it did, it would be a simple matter to do a genioplasty. I say simple, but it can be done in a oral surgeon's office and drop this thing back, and put it back in here. But when we get through, this looks quite normal. So just remember that when we finish up the case here. Alright, here we've started this already, and we're going. Now I want to point out that you always wait to extract the teeth until you have the brackets and everything on and you're ready to move, so that the day you take the teeth out, you start moving this back and this forward in here. Now if you come out a little to class 2 or class 3 as you're going, you can see what's happening. Then you can use class 2 elastics, or you can come in here with class 3 elastics, whichever one is necessary, so that you end up with a class 1 relationship between the teeth. That's just common sense, but I hope that you realize you can do that as you go through the case. Now this young lady had complications that you don't find in a lot of cases. She had periodontal problems around the teeth, and so we're moving periodontally involved teeth up here, and that's a shaky business. Now I asked this young lady if she smoked. If she hadn't been a smoker, I would have been very reluctant to go in and do this case, because it makes the periodontal situation worse. But she wasn't, and so we went ahead and started it, even though she had bone loss, and you can look at the bone loss where it was when we started and where it is after we finished, and I can't tell that there's much difference in it. In fact, I just saw this lady last Sunday at church, and she's still got a beautiful set of teeth, and that's from 1987 when we started this. We finished it about a couple of years later, be about 89, something in that area. And here it is, 2014, or it's getting pretty close to that. So this has been done for a long time, see. So, and it's still stable. She's still working with it. I've got some pictures of her up a few years ago. I haven't got some update pictures on her yet. Now, here it is after we finished. Now you remember where the begonias stick it out, and here now the teeth are like that. Let's go back, and I'm gonna show you where it was. And if you think this can't happen, it darn sure does, you see. Now the point of the chin stayed where it was, but these went back, and these teeth are lined up somewhere back in here. Now, I'm going to go back again, and you look at, excuse me, jumped too many. You see where the bone structure is at this point. Now, this begonia did not move, but the alveolar bone that supports the teeth did go back, move back, but it still didn't make her look bad. So I didn't recommend any genioplasty here, but you could have if their chin structure was sticking out too far, and it was an aesthetic thing. But she knew that she could do this. Now this picture right here was taken in 2010, right here, so that's 87 to 97, 97 to 2007, and then 2010, that's of 23 years, and now it's another 3 or 4 years onto that, so it's been done quite a long time, and it's still quite stable. Now the bone structure at this point is just about as good as it was back when we first started the case. You see the bone structure here around the 6-year molars. That's the second molar. And now you look at it at this point, it's almost the same. Now, she's still got some periodontal problems, but she takes care of her teeth quite well nowadays. Now, here you could see and this is, you got to kind of wonder if I'm going to drag these teeth all the way up to here, you see, and pull this tooth out, it'll be coming something like that. So these roots of these teeth have to come forward quite a ways in there to accomplish that. Now, if this is a smoker, you're going to have some problems with it. And we thought we were having problems. We slowed down and went slower. And she's got periodontal pockets up above too. In fact, they have periodontal situation in the family. So she's got the genetic defect there that makes periodontal problems pretty prevalent in that family. So they have to really watch their teeth, watch their bone structure as they go along. She's taking care of it real well now. Okay, we extract the teeth, and now we start immediately. We've already moved that tooth forward. It's kind of tilting over here. We want to bring these roots up. Now, as you go, it'll look like you've got more pockets and deeper pockets, and because the attachment really hasn't been broken, you will drag this forward and it'll look like you have more bone loss. If you just sit there a while, the bone fills back in as long as you didn't destroy the attachment up at the top. as you go forward with it. Now, so here we are along the way, and the bone looks better in this picture. This is January of 88 right here. And let's see, the picture here was, well, I've got the date gone here, but it looks like she was 25 and 5 months at this point. The bone looks worse here than it does after we go to this point. Now, we stopped in there and rested the case for a while, and I told them it's a possibility you lose the teeth, but she wanted to go ahead anyway. She had been to 2 places, and they wanted to do surgery on her to correct the class 3 problem. So we've done this without any surgery as far as jaw surgery at all. So here we go. Now this is 5 of 88. We're up at there. The bone structure looks much better around here, but as we drag this forward, you'll see a widening of the periodontal membrane and everything. But the bone will fill back in after you get into place. Here's an 88. We're coming forward with it. Now that's number 7, and I can't see the date on that real good, but we got the crown almost everywhere. We've got to bring these roots up to here. See, so that's going to be, and where we take an arch wire like here, this arch wire would be going down this way as we pull on it, so that keep these roots coming forward as we do this. This is touching over here, and these roots have come forward quite a bit. Now these have gone back to some extent too. So we're correcting the class 3 problem as we go along. Alright, at this point, we've got the roots pretty well paralleled, and it looks like we've got pockets all in here. But wait until we leave this alone for a while and hold it there, then bone fills back in around these areas to some extent. Now it looks pretty bad over here too, but this bone will fill in back in there. Now our upper 3rd molars are just going to be kind of left hanging in the breeze. Okay, here we are clinically doing this, and we started out with a little wildcat wire. Just you can use an 016 or an 014 tie wire if you want to, and you can put some expansion loops in it. Now this wire, it goes back and it's longer. It'll be setting out in front of the teeth when you go to wire it in, and this loop will be open like that, and as it pushes this out, you'll have your loop will be kind of back like that, so the wire's pushing on this all the time to expand it up above with that upper arch wire. Now down below we'll have to get some expansion too, so we'd have loops that are open, and when we get them tied back in there, this loop will be closed. So it's trying to open this space, and it gradually does. And as we get space here, we're going to start turning this tooth around, and you're going to have some stripping on that. It just will almost invariably happen. So, and the problem for something like that is that the anatomy of a lower anterior tooth is kind of odd to look at. I'm going to just draw one off, like if you have a lower anterior tooth. This will be pretty flat on this side, and then it's rounded off as it comes up here. Now if you look at the tooth just from the front part, it's wide here, and then it tapers off, and it's pretty narrow down like that. So when you turn it sideways and you have this this thin part of the tooth to the labial, the bone will be right in here. So when you start to turn it, this will just actually go through the bone structure, a lot of area like that. Now, if you could come back in, say, and it's kind of a funny shaped bone in here. If you could torque this tooth and bring this root in and then turn it, but it'd be very difficult to put a bracket on the, but I guess someday we'll do that, and bring that in, and then you can turn it where it would be in the bone structure. Now watch this as we go through. It strips down and then the gum comes back, but we have lost the attachment on that. So as we rotate, this is just something you need to know. If you get somebody with a lower anterior tooth that's nearly 90 degrees rotated, you're going to darn near always strip through the tissue and some of the bone in doing the case, or just tell them to start with. That doesn't mean you'll lose a tooth. Alright, we make space in here. We're pushing apart and opening this out to have a loop here that's condensed now, so the wire's pushing out, and then we've got spring in here is pushing it apart in this manner right here. And up here this loop is condensed, so the whole thing is pushing. We're trying to widen the upper teeth out also. Now the cuspid will need to be tipped and rotated, which is an obvious thing you do in any kind of orthodontic situation. Alright, we are going to line this up, and then we're going to expand this upper arch to get this where, as we advance the lower mandible a little bit, as we get out from here and advance it, it'll be a wider area come in to fit on the occlusal surface of the upper arch. Okay, we're about ready to start rotating this tooth. You need enough space in here, to actually spin this tooth around, and we can do that by pulling back here with a chain, or actually pulling back on tooth from this side, which will tend to rotate it. You can actually take just a little chain, and you half hitch that chain onto the arch wire itself. We'll show that on rotating teeth. You bring the chain around this tooth and hook it around the bracket, and as you get space in here, that chain will be pulling on it from this side, and this tooth will just rotate around like that with that chain elastic on it. Alright, we've still got the prominence of the lower jaw, but it's looking a little better now. We've gone back some of the way, but some of the fullness is still in there, and a little deficiency in this area right here. So we're still working that way, and we haven't really finished this by a long shot. So the time we get it finished, it'll look much better than that. Now, this is 5 of 87. That's not too long after we started the case. And if I'm looking at this correctly, there's a little elastic chain tied around here, goes around this tooth, comes out over here and hooks onto the bracket, and so it's kind of spinning this tooth in this direction. It's spinning it around like that to pull it in place. As we do, it's going to tend to strip right down here on us. It's already done some of that. It wasn't perfect when we started with it. Okay, we're coming forward with a molar, and we're going backward with these teeth. We can do that with that little arch wire. It started immediately. So here we've hooked the elastic chain back here, and we're closing these bicuspids back. Now we need to get in there pretty quick and get our big daddy arch wire to expand that upper arch too. Alright, here we are with the brackets on, and we've expanded the upper arch. We've got space between the teeth here and here. Probably have to move this over a little bit. This is lined up with very little space in it right now. Now we're closing with elastic chain right here. See, we're hook this chain elastic right there. Now if you want to rotate these teeth some, you hook this on the lingual button on and you pop it through and then bring it down, hook it under the elastics on these two teeth, and that's pulling back here and it's pulling forward over here, and it's also rotating this tooth in this direction. As you pull it forward, it rotates that some. Alright, here's the large overlay type arch wire that we put in the upper area, and it's expanding the upper arch quite good. Alright, we've expanded out, and we had to start using some buccal root torque in those upper molars now to keep the roots going out with us. Now down below, we've come further forward over here. We got this tooth leaning, so it's really no better off than this one over here coming forward bodily. Alright, we've rotated. This is January 28th of 80, I don't know, it's 87 I think. Now that is stripped off to some extent in here. We go ahead and keep it like it is, and we'll torque this tooth in. Now we're in a rectangular wire, so we're going to put torque in to bring this root back into the bone structure on this side. Now that's coming along fairly good. Okay, we're about halfway through this. This young lady puts on a few pounds, and as you can well know, it affected her looks. Now 25 or 27 years later, I saw her just Sunday in church, and she's a stewardess on one of the airlines, and her husband, and she has a son. He's a class 3 too, but they didn't bring him into our office to do. Anyway, she loses some weight, and she will look a lot better as we get down the way. Okay, we're quite a ways into the case right now, and we're doing another thing here that you need to understand, and I don't like these little composite or these clear brackets. You can't torque good enough with them. I want to put reverse torque in these upper anterior teeth to bring their root structure out so that they aren't laying out like this, they're more or less like that. And to do that, you've got to have a vascular bed go in front of the bone that's moving out, you see. So you got a pretty tight muscle up here, so we put a lip bumper in, and this lip bumper will run interference, and it'll have a little space between the back part of the lip bumper and the tissue, and you keep that space in there as you reverse torque these upper anterior teeth that bring them out that way. That's a kind of a trick. You need to know how to make those lip bumpers. They fit in that auxiliary tube, everything. Alright, she's looking real good as far as the tooth-wise situation. And we look on the side, and we're nearly class 1. Now, as we go back, we've got the molars almost in class 1 relationship here, see. this upper molar coming down and this one back here. So it's pretty well done. As we come along on the case, this tooth gets to look a little better. We're putting torque in there. See, we got some reverse torque, or actually it's torque that we got on these lower anteriors to bring this root in where it was coming straighter out to start with. So we're torquing it in as we go. Again, same situation. You can see how that lip bumper, it's got some play up here. We're going to reverse torque that. Alright, the upper arch is lined up quite good at this point, and the lower arch has got a few more months of work in it to do it. We're in 89 now, 87 to 88 and 89. We're getting close to a couple of years in treatments time here. Alright, the midline looks good here, and the torque and everything, and the tissue is looking better around this tooth. I don't know if she ever has done anything with that, grafting that or not, but it looks pretty darn good right here, and we're in a good class 1 relation now. Okay, we've still got a little space to close over on this left side, looks to me like, and everything else is lined up pretty good. Alright, she's lost some weight, and she's got a little prominence of the chin, but it's not detracting from appearance. She still looks good. So I wouldn't recommend this. This was a 91, and we're just about to finish the case, or maybe we have finished it. She's probably been out of it for some time now. She's not brushing them like we would like, but there it is in 91, and this was 87, which is about, let's see, that's about 4 years there. So she's been out of this for some time now. When we look at from the side view, you can see where we took this out, and you see this molar. I didn't get a side view with in the mouth here. It's good, so you can see it, though it's virtually class 1. From the other side, same, and we widen this arch out with that Big Daddy wire, like that to that, you see. And the lower arch is somewhat widened out down here with the cuspids and everything. It's had to enlarge that, so it's bigger down there and bigger on the upper too. Alright, this is 91, and it's looking quite good. Now we'll go through it. Alright, the lady, I didn't see her for many years, and then we moved out to Glenrose, and she recognized my wife, and by her name. In fact, my wife had her son in her Sunday school class, and I didn't know that this was the lady I had treated either. And she came up and introduced herself, and I was thrilled to death to see that her teeth were still beautifully placed, and I had all these slides on her case to start with, and looking at the facial structure, you would find very little deficiency or the prominence of the jaw, even though the chin protrudes out just a little bit more than you would really want it if you were doing it in an ideal situation. And the teeth look gorgeous, you know. It's been from 87 to 2010, and so it's about 20-something years, 23 years, I think, something like that. And that's darn good, you know. And she didn't have to go through jaw surgery or anything, and it's very stable. And I've done this on a lot of people, and it works. Now, she brushes the heck out of them because we did this, didn't cause this recession of the gum tissue. She needs to take care of them a little better than she's doing right here. That tooth that was stripped The tissue looks just about as good on it as it does on the other teeth around here. Now that was 10 years in 2010, and I saw her just the other day, and so we stick another 3 or 4 years on this and they still look good. And that's a good class 1 relation. Back in the back, same thing over here, overjet, overbite, and the torque on these teeth. So we brought these teeth back in. We didn't leave them tilted like that. Brought them back in, brought the roots of the teeth back in. She's had a lot of fillings in the teeth since the time we took these before, but everything's looking good. Down on the bottom, so here's where we started, and there's where we are in 2010. Here's starting on the right side of the mouth, and there's the second molar coming up. The wisdom tooth kind of still in there, just popped down on the side of that. She could get them out if she needed to. Alright, here is the Panorex in 2010, and the bone structure is not too plain on that, but you can see the bone looks as good now as it did when we first started the case, even though she's got this periodontal defect. The upper wisdom teeth are coming in. They may grow in and hit the tissue down there and you'd have to remove them, but this is a good class 1 relationship. Still got a little space right here that hasn't closed up. And here's the models that we took, and it doesn't look as if it's perfect class 1 here. The midline's off just slightly. It's more of a class 1 on this side. That's 2010, which is 23 years from the time we finished the case, and now we've had another 3 or 4 years on this, and you got somebody that's been out over 25 years, you see, this treatment. So it went from 87, and there's 88, and there's 2010. And see, this Begonian is sticking out here, but it doesn't detract from her appearance. It seems like the mouth fills in around that area. Now if you go back and look at the Begonian to start with in 87, and now look at it, that's 88, it was back like that, now it's here. So the point is, the chin button is protruding out, the teeth move back in kind of a bodily movement of the teeth. Okay. Alright, this is case number 2, and I'm going to stop right here, and we'll come back and finish that. I'm going to push F.